So we're going to use this half head to look at a lot of the structures associated with the oral cavity as the opening for our digestive system. Now there's a couple of things that, because it's a mid-sagittal section, are a little harder to see, but I will go ahead and try to explain them as we're going. So when you look at the opening to our mouth and our oral cavity, then these are our lips we're seeing cut and cross section. And just on the inside of on the outside of the teeth, there's a space between our lip and our teeth. And so that's called a vestibule. So the way you think about it, if you chew tobacco, you put the tobacco in the vestibule. Okay. Now, midline, which has been cut, where our lips are connected midline, there's a rigid tissue that would be midline here, and a rigid tissue that would be midline here. And those are called frenula. And so the inferior one would be the inferior labial frenula, and the upper one would be the superior labial frenula. Probably the best way for you to see that would be go home, look in a mirror, pull your lips down and up, and you'll be able to see it. And then there's this tissue that holds the tongue to the floor of the mouth. That is, in the back we have the root, which is a very defined, thick piece of tissue. But under your tongue you have a thin layer of tissue that supports the tongue to the floor of the mouth. And it's a frenulum too. So it would be called the lingual frenulum. And again, the best way to see it would be to look in a mirror, elevate your tongue, look in the floor of your mouth, and you'd see a ridge. Now, some babies are born with that frenulum coming too far forward, and then their tongue is mobile. They have trouble learning to speak. So they were historically called tongue-tied babies because they had trouble speaking. We know surgically now we can shorten it and resolve that issue. All right. So as we go through the oral cavity here, there's a downward extension that if you looked in a mirror you'd be able to see, which is your uvula. And so this is the uvula. Now, associated with the uvula and the soft palate are some ridges. And if we look at the ridges singularly, we just see a ridge that is right here, and we see a ridge that's posterior to it right here. So these ridges are called arches, and they're called arches because if you looked in a mirror and looked in your throat with a flashlight, you would actually see that they create an arch that's a narrowing, so that you keep food in here to manipulate it, and then you pass it through these arches to swallow it. And if you rub on the sides of the arches, it gags you, and that makes you not swallow it and bring it back up. So the arches here have names based upon their relative location. So the anteriormost arch is the palatoglossal arch. So palato is a reference to the soft palate, glosso is a reference to the tongue. So it's the one that's anterior and closest to the tongue. Now when we go posterior, then there's a ridge on the backside right here, which is the palatopharyngeal arch. So again, Plato is a reference to its relationship to the soft palate, and pharyngeal is a reference to this cavity here, which is your pharynx. So what separates our oral cavity from, and what some people call the buccal cavity, from our nasal cavity is a hard palate anterior, and the soft palate we were just talking about posterior. So the hard palate is actually made up of two bones that we learned in the first class, and the first one is the Palantine bone of the Palantine process of the maxilla, and then the tail end of it here is actually the Palantine bone proper. So we have two bones that make up this hard palate. And the roof of our mouth is ridged on the hard palate. Your tongue uses the roof of the mouth to manipulate food, which is why if you eat a white bread peanut butter sandwich, it gets stuck on the roof of your mouth because your tongue sticks it up there trying to manipulate that food to help you chew it. So as we continue backward then, we actually have a pharynx, which is our throat, and the pharynx that's posterior to the uvula and then superior to the soft palate, this area is called the nasopharynx. The area between the end of the uvula and the start of the epiglottis here is the oropharynx. And then this space back here below the epiglottis and above the opening of the esophagus, which contains the opening to our larynx, is called the laryngopharynx. So we have three areas: nasopharynx, oropharynx, laryngopharynx. So if we go back to these ridges, which the first one, remember, was our plato-glossal arch, and the second one here is our plato-pharyngeal arch. When they actually form an arch, the opening between the sides, each side of it, is called a fauces. And then what happens when we swallow is we pull the uvula backwards and upwards in the soft palate so that we can close off the nasopharynx. And when we do that, this arch collapses and the opening narrows. And that assures that we don't eat too big a wad of food that gets caught down here and chokes us to death. So the fauces is wide when you're not swallowing and narrows to a slit when you're swallowing to help protect you from swallowing too large of food mass, which we call a bolus. Now, we have three sets of tonsils, and tonsils are aggregated lymphoid tissue. Their function is probably to a greater extent in children than adults, which is why we see kids more frequently with tonsillitis than adults. And the basic pattern is kids are less discriminating about what they put in their mouth, so you have to have all this immune system to help take care of that. So we have a tonsil that's associated with our tongue here. So this is the body of our tongue. This we call the root of the tongue. And then this structure right here, which has got a separation from the rest of the tongue, is the lingual tonsil. And if you actually look at the lingual tonsil from a posterior view of the tongue, then we can actually see that this area here, this real granular, is our lingual tonsil. In a little bit, I'll actually show you that on a real preserved tongue. We can see how the lingual tonsil actually looks. Now, there's a set of tonsils, and we have one on each side, so we have a left or right, where this is a midline tonsil. And they sit between the two arches, the plato-glossal arch and the plato-pharyngeal arch. So this aggregate here is called a Palantine Tonsil. And we have one on each side of our mouth, the left and right Palantine Tonsil. And clinically, those are the easiest tonsils to see. Use a tongue depressor, you can usually see these tonsils pretty well. And then we have a large tonsillar mass that's on the back of our nasopharynx. And it's oftentimes called adenoids. And it's the pharyngeal tonsil, which is this aggregate of lymphatic tissue back here. And it's obviously the one that's very hard to see because it's behind the uvula and the soft palate. So to help us moisten food, lubricate food, we essentially will create a wad of food with our tongue called a bolus. Then we have salivary glands that supply an increase in liquid of the food. You can demonstrate that by eating soda crackers, no water, and then after a while you can make a paste out of it because of the actions of the salivary gland. So our largest salivary gland is associated with our masseter muscle, just inferior and anterior to where the ear should be right here. And it's called the parotid salivary gland. And it's the mass that you can actually feel in that area. If you feel the angle of your mandible just above it, there's a mass of tissue that's kind of soft. You can feel it. That's that. So today, because we have a vaccine for mumps, then mumps used to target this and make it swell really big, which created tremendous pain when you were a child and you had it. And so what happens is this produces saliva, and then the duct that drains it crosses the masseter muscle under the skin. So the easiest name is to name it after the gland itself, which is the parotid duct. But historically, things were named based upon the name of someone who discovered it. And so it's also got a name called the Stenson's duct. And then what it does is it comes across the anterior part of the masseter and then drops through the buccinator muscle. And so it actually drains saliva to your cheek on the inside. So you could actually demonstrate it by going home, getting a wedge of lemon, going in to where you have a mirror, get a flashlight, bite the wedge of lemon, and then open your mouth, and you'll be able to see saliva dripping in your mouth. Because when you change the pH of the mouth, it causes the salivary glands to increase their production of saliva. Now, below the mandible, we have another salivary gland that we can see and palpate just below the angle of the mandible, which is this mass right here, which is called the submandibular salivary gland. And then the submandibular salivary gland has a duct that drains it. So I have another model that has been kind of cut away so that you can actually see that. So this was our first salivary gland. We did the parotid with Stenson's duct. This is the one we were just talking about, the submandibular gland. Then we have this little green duct that drains to the floor of the mouth. And so it's called Wharton's duct or the submandibular duct. So if you were to look in a mirror, look at the floor of your mouth, remember we have a ridge midline, which we call the lingual frenulum. And on either side of the lingual frenulum, you'll see a little opening. And that's the opening of the two Wharton's ducts, one from each side. So they dump saliva in the floor of your mouth, which is why we always build up more plaque on our teeth in the floor of our mouth and than we do on our anterior upper teeth, because we're constantly evaporating saliva, breathing in and out, concentrating it. Bacteria play a little game with it and create plaque for us. So our lowest one is called the sublingual salivary gland. And so that's the deepest gland we see here right in the floor of the mouth. And it's just under the tongue, hence the name sublingual. And it has many little ducts that open it. The most common number you would see are 4 or 5. So you can find the Wharton's duct opening, which is easy to see. There's a ridge that you follow, and you'll see openings along that ridge. So they're called Renovus ducts or the sublingual duct. Now, with this model, we can actually see all three. We can see 2 of them. So this would be the submandibular salivary gland, and then this upper one would be the sublingual salivary gland that we're able to see.